This Health IT In-Depth program is sponsored by Maximus, eVisit, and Carasoft. Welcome to the latest program in the In-Depth series from FedGov Today. On this program, we'll look at Health IT In-Depth. I'm the host of FedGov Today, Francis Rose. The federal government's approach to health IT is changing both in the way it manages the care it provides to people and in the way it interacts with private sector providers. Some of the technology solutions the federal government's using are common across the modernization field. Some are unique to the health sector. On this program, you'll go in-depth with movers from government and industry that are leading health IT efforts. Leaders from the Federal Electronic Health Record Modernization Office, the Centers for Medicare and Medicaid Services, the Office of the National Coordinator for Health IT, Maximus, and eVisit are here to discuss what they're doing in health IT now, what it means, and what's ahead for health IT and for government-industry collaboration. We begin with Kelly Harrar, Vice President for Federal Health at Maximus, and Bill Tinston, Director of the Federal Electronic Health Record Modernization Office. Welcome to both of you. Thanks for joining me today. Bill, I start with you. As we talked about a little bit before we went on the air, you now have MHS Genesis and the Defense Department online. The collaboration with VHA is starting to take form, Coast Guard and others. Where is the Federal Electronic Health Record today, and where are you aiming for in the next year or so?
So the Federal Electronic Health Record, and I appreciate you using that name for it, is MHS Genesis, as DoD refers to it, as well as the implementation at the VA. We've implemented at Coast Guard, the entire shoreside of Coast Guard. We've also done NOAA, National Oceanographic Administration. We have coming up the Armed Forces Retirement Home. We have NSA coming up and probably future federal partners. But we're 209,000, 210,000, something like that, users of the system. So that's clinicians, providers, other users of the system. 10 million patients are being served by this single record, this Federal Electronic Health Record. And I want to make that point again. So while you said MHS Genesis, it is a single Federal Electronic Health Record about the patient, not who delivered the care or where the care was delivered. And it's pretty amazing that we've gotten to where we are. You mentioned DoD's completion of their deployment. That happened at the only joint DoD VA facility at the James A. Lovell Federal Health Care Center in North Chicago. That was done back in March, I believe. And it was incredibly successful, the most successful DoD deployment and the most successful VA deployment to date. I look forward to what we can do with other federal partners, because what DoD and VA have created is a massively powerful set of capabilities that it incrementally doesn't cost a lot to bring other federal partners on.
What are the capabilities that those providers have now that they didn't have before wherever they were in the system, before they were a part of the FEHRM?
So it's different depending on the department you're coming from.
Okay.
Coast Guard was coming from paper. DoD was coming from a system called Alta. VA is coming from a system called Vista. And the capabilities are different, and the standardization amongst those systems and within the health systems are different. What they get now is a common set of workflows. They get a coordination-focused, workflow-focused system instead of a note-focused system. We get the same information because it's one patient record carried between the DoD and the VA and other federal partners. So DoD makes veterans. So most people who are seen in the VA were probably also seen in the DoD health system as well. And it carries through to benefits, right? We talk and we hear a lot about exposure, right? And so bringing that exposure information in, presenting it in the clinical workflows so that it can be added to or considered in the clinical decision making, but also from a benefits perspective, right? We've made national commitments to veterans about exposure and what we owe them for that. And so capturing that information and bringing it into the system and bringing the benefits side in is incredibly important as well.
Kelly, welcome. It's great to see you. It's striking to me as we think about what Bill just laid out there that the Coast Guard moved from a paper system to this system. Some of these organizations that are thinking about this transformation to digital first, what are some of the key points that you're seeing organizations that are successful in doing that digital first transition? What are they doing to get there that they have that success?
Well, thank you, and glad to be here today. I want to boot stomp what you've said, Bill, because the first fundamental part of modernization and digitalization is getting the electronic health record up and running. And it's about adoption. And getting that fundamental baseline record there that follows the beneficiary or the patient wherever allows us as partners to the federal government to bounce off of that and create patient centered home of care. They get better outcomes. They have more information about their health. And also importantly is provider efficiencies that are created through this one health record. And so we are very excited to partner across the federal government agency to help them with adoption, to help them with efficiencies. There's so many different ways that the modernization of the healthcare record can take us. We can plug in our devices that we use every day, can intake that. We can focus on military, across the DoD, the military treatment facility utilization, better, more access to military beneficiaries. And then as Bill said, they are ultimately coming into the VA system after that. It's wonderful to see, and I'm so excited to be here with you.
What are some of the things, I want to follow up with Kelly just one second, Bill, but I'll come to you in a moment, because it strikes me, you just mentioned like smart devices and those kinds of things, and I wonder if we're just now scratching the surface of what all the things are that eventually will plug into that electronic health record for the care provider to be able to know what's going on with this person that's in front of them.
Very much so. We are in embryonic days, and I think the field is being created by having this centralized system of repository. And right now, I use my watch for wellness, all kinds of things. It goes nowhere except for me. But the digital electronic devices can help patients articulate their symptoms better to providers. It can be a read ahead for providers when they come in and see. It's just exciting where this can go. But we have to get the electronic health record in place and established and adopted throughout these systems appropriately before we can take it much farther.
Bill.
We have to be part of the mission.
Right, so getting the record in place is absolutely where we have to start, getting that baseline, that common record that we're working from. But you said something that I think is really important. And we connect a lot of things in here, and all of that drives transformation, and all of that drives change management and adoption. DoD's done this, 138 major sites, the entire DoD. VA is working this. Where did the problems arise in those massive health systems trying to deploy this common record? In adoption, right? You're changing the way people do their jobs. You're changing the workflows. You're changing what the future might look like as we bring other connected devices in, as information is able to be shared, as you push converged workflows, as you, sometimes people suggest you're suppressing innovation. In fact, what you're doing is allowing for innovation, and you have the ability to promulgate that information across the health system quickly. But the key to all of that is the adoption. And that's where we've had the problems, and those are the problems we're overcoming. And I think that observation was just very powerful.
What are some of the steps that you've taken to overcome those obstacles to adoption, Bill?
So when we did North Chicago, James A. Lovell Federal Healthcare Center, we were talking about ourselves collectively as Team FHCC. Why is that important? Well, so you had the firm, you had a massive DoD program, you had a massive VA program, you had a director of the facility there that's 10 years ago, we integrated the facilities, but we didn't integrate their IT and their infrastructure, and it's not just the health record that wasn't integrated. But what we were focused on is making that site work and creating a new baseline that would work at other joint sharing sites, allow the two departments to work together, their health systems, to work together irrespective of IT limitations. I mean, that was the goal. I don't think we're quite there, but they can certainly do it better. but it was that grand team focused on one mission, and it was doing it together. What we've learned, DoD and VA and our other partners, is we do it better when we do it together. DoD brought solution experts in. We called it Pay It Forward. But they brought experienced users of the record into that facility. They sat there next to VA physicians and VA clinicians and helped them work through it. Even if the workflows weren't identical, they were familiar with what we were doing. Those are the things we're doing, but adoption is the key to succeeding with the record and growing beyond the capabilities that we're initially deploying.
And while Bill was talking about adoption being the key, Kelly, you were nodding very enthusiastically. What resonated in there with you?
Well, a lot, but what I would say is the standardization and the adoption are so critical, educating the users on how powerful this record is. And sometimes when you have massive sea changes like this, people get stuck. I want to do it my way. I'm an Air Force flyer. This is my record. This is what it looks like. I'm a submariner. I have to have this in my record. And so what I think people need to realize as the adoption is taken on is the flexibility of the system. Standardization is not going to take away the individual needs of the beneficiaries and the patients. Veterans have completely different needs than active duty service members, their family members. So all of this standardization doesn't mean there's limits to their healthcare record or where they can go. It just means that there's a simplified area where they can go look at it, and a part of the adoption is educating the stakeholders and the users to that fact.
It's almost a customer experience element, isn't it, Bill, in educating that user, that provider. This is what's going to happen to you when you sit down with a patient, and this is what you're going to be able to do now that you weren't able to do before, or this is what the system will do so that you can concentrate on the patient, that kind of thing. Am I on the right track?
You're absolutely on the right track, and it can be, and we encounter this. Sometimes it's somebody else is going to do that now. Your job has changed, because as we looked at this, it's not really about implementing an IT system. Anytime you do an enterprise IT implementation, it's about the business transformation or the healthcare transformation or the clinical transformation in this case. Jobs move, activities move, jobs are redefined, and the process for being successful is redefined. And that's difficult, and it's incumbent upon us to help people understand why. Everyone does better if they understand why things are changing, why and how, and make sure they're equipped to succeed going forward. Everyone doesn't make it through that process. Most people do, and they make it through at different rates. But that's what we're really doing, is transforming the way they're executing their jobs. So you mentioned sort of a customer-focused thing. Then the next part is how do we, that's on the clinical and the healthcare delivery side, how do we get to those patients? How do we connect those devices? How do we get the right portals? How do we share this information with the people who own it? It's about people, right? It's about military members, families, VA beneficiaries, Coast Guards men and women, and so on. How do we share that information? And honestly, Francis, we're at a point now where we've created interoperable connections bidirectionally with the entire community healthcare system. So we're at a point where we have access to, if it's electronic, most of the data about a patient. So how do we share it with them? And how do we make them more successful in their endeavors to protect their own health?
What Bill is laying out there, Kelly, in another part of federal health IT or federal IT transformation might be referred to as business process analysis. Exactly. Is it the same concept?
Absolutely.
In this, it just applied in a different way?
Absolutely, absolutely, and it's critical and paramount to the success and the usability of the systems. And it's, for so many years, I think we've gone to so many different portals and so many different records, having that one sense of here is everything, and then breaking it up into bits and pieces as you implement it, and it moves through the system, I think is critical. And so how we take that attribute of the system and we apply it to the user or the patient it's critical, and doing it correctly and taking your time and understanding what the functionality should be and how to measure its success is also critical as well. And in many of these large system implementations, you're not going to get it right out of the gate. Okay, you're going to have to change your strategy. You're going to have lessons learned. You're going to have things that stand out that are really good that we want to keep doing. And we're going to go learn from the lessons and maybe adjust and tweak our strategy a little bit, but all in the benefit of succeeding in the mission with the client.
So I really appreciate that you said that, because I didn't grow up in healthcare IT, and sometimes I wonder why we differentiate it from other IT.
What are we doing here?
Well, no.
Are you questioning the premise of the show, Bill?
I'm not, actually, but I am saying, you mentioned business process transformation. I think you said it a little bit differently. I came from ERP implementations.
Yep.
So we're doing the same thing. It's just the business is healthcare. The customers are patients. And the outcome is more important because it's people's health.
Yep.
And it's people's health data that we're dealing with. So it's different in all of those respects. But from implementing an enterprise system, it's the same process. What are we doing now? What should we be doing in the future? How do we standardize? Where don't we standardize because it doesn't make sense? And then how do we capture the data about what we did so that we know what to do next and how to refine and optimize going forward? And now we're in a position where, one, we can look at a process and we can look at the numbers around that process and say, hey, maybe we ought to do that differently. And then we can propose something, make changes, and then we can see how it worked. So it's not a who's loudest or who's been there the longest or who's usually right. You can actually propose something, implement it, look at it and say, that worked, let's do more. That didn't work, let's do something different. And we weren't in that position before.
Kelly, are the metrics, you talked about measuring success a moment ago, are the metrics of deciding whether something works or didn't different given the fact of the mission of serving a patient and seeing to his or her health care?
I think you have to look at it from different angles. So I'm going to talk out of several sides of my mouth here. I think metrics are different for a provider. I think metrics are different for the beneficiaries, for the patient, for where they are in the healthcare continuum. And I think, as you look at the adoption of this mega ERP system, I love that, Bill. I used to be in finance, and one of my last projects in finance was implementing an ERP system and integrating it with Salesforce. So I think you have to take a look at who is on the other end of this system and how do we measure, because it's not going to be a one-size-fits-all.
All right, a lot of focus, Bill, on the VA in particular about timeline. Are we focused on the wrong thing if we're focused only on the timeline about when is it going to be done or when is it going to deploy to more locations and all of that kind of thing? Is that too much of a black or white distinction about judging success?
So I think so. If you, and I know you did, if you paid attention to the early implementations on the DoD side, they went out and they did 4 sites. And then they paused and they looked at how things are working and they said, everything's not right. They got a lot of very public attention that they didn't get it right. And they spent some time, they spent a couple years working through what it should look like. And then they started implementing again. And then they brought those changes because it's a single system, common workflows. So they started rolling out the new workflows and adjustments to the processes, including to the initial sites. And they started to create success, right? And VA's doing the same thing. They're in reset now. The reset is focused on getting the 5 initial sites right, getting North Chicago delivered, which happened, and getting the foundation in place for future deployments. And I think the Secretary of the VA said in 25 they're going to restart deployment activities. I think you'll see that, and I think they're doing the right thing because it's about healthcare delivery and it's about the patients and the veterans on the back end that you're supporting, and you want to get that right.
What's the best way in your view, Kelly, to measure, to look at data to determine that not just the care that the individual patients are receiving is improving, but that overall the service delivery is better, more efficient, faster, whatever those metrics are?
Well, I'm going to give you a soft one, and then
Okay.
maybe you can quiz me and push me harder. But we are facing burnout from medical providers right now. There is a massive shortage, and so one of the things that we need to focus on is how do we make their job better and easier? How do we attract more people into the direct care system to want to provide care to people? And I think an important measurement is how successful we are in making their lives easier. And so whether it's using AI on transcription, being able to deploy that right into their health record, telehealth, automated scheduling, different hours. I mean, I get excited about this stuff. Am I lifting off my seat here? But I think
Just a little.
just a little. So I think there's a lot of things that we need to look at to make our medical professionals' lives easier. And I don't want it to be necessarily a scorecard, but I want it to have an outcome that is very clear and very tangible to say, yes, this worked.
Is that part of the tracking that you do as you move from location to location, whether the providers are telling you, my job's easier now because I'm using this?
So there's a few things we do there. Like right now, the annual Federal Electronic Health Record Summit, User Summit, is happening. We're on day 2 of 3. And that is explicitly what you just described. We get those people together virtually, and we have those conversations about what works, what doesn't work, what needs to be improved, what maybe they didn't know, because it's a bi-directional conversation. We have the solution experts there. The other part of it is, and it's really the health system that does this, not the implementers, but they have different data and more data about their processes and how they work. So they can look and they can decide to do things differently. And as I said earlier, it's no longer, I think this will work. It's prove it. We have the data. We know how the changes have impacted the processes or the outcomes we're seeking. And as we switch, you mentioned digital first. I know the Defense Health Agency, that is their focus right now, is digital first. Reaching the patients and reaching beyond the health system and making sure the experience is right. And I appreciate that. I help my parents who get their health care from the military health system, and I have to go to the pharmacy for them. I got to take them to appointments. And so I always do my own little assessment, right? Take my dad to the audiologist, and I said, so, at Walter Reed, so how do you like the new record? How do things work? And this is not scientific, but that particular audiologist said to me, it's much better. I spend less time documenting the encounters after hours. And that's great news. That goes to that burnout. And I'm not suggesting that's universal. I'm suggesting that's my little anecdotal when I take my father to the doctor, and that's the kind of feedback I got.
We covered a lot of ground in this conversation. Bill, Kelly, I appreciate your time very much. Thank you for joining me today. You can read more about electronic health records and digital modernization in health IT and find links to the resources we talked about at fedgovtoday.com. Up next, opening up the code and the opportunities in health IT. In Depth continues in a moment. Don't go away. If you want insights from agency and industry leaders on the latest topics in technology, management, workforce, defense, and acquisition, sign up for the FedGov Today podcast with me, Francis Rose. I release new episodes every Tuesday and Thursday, so you'll stay up to date on the issues that matter most to federal government leaders. Listen at fedgovtoday.com and everywhere you get your shows. Don't miss out on the conversation. Follow the podcast today. Welcome back. Software underpins the transformation in the health IT sector in the federal government that you learned about in the first part of this program. The way the government gets, uses, and maintains that software is different now than it was just a few years ago. Andrea Fletcher is Chief Digital Strategy Officer and Director of the Digital Service, the Centers for Medicare and Medicaid. Sachin Agrawal is Chief Executive Officer at eVisit. Welcome, both of you. Thanks for joining me. Andrea, I start with you. You used a term recently that I think is interesting. You said CMS is opening up our code.
Yeah.
What code are you opening, and why is that important?
Yeah, so at CMS, we write a lot of software, right? And we've had a long history actually at the agency of building open source software. So building software that we actually build in the public with other people using open source repositories and packages, because we work a lot with the private healthcare sector, right? So the best examples of this are called Blue Button 2.0 or data at the point of care. These are bulk FHIR, FHIR, APIs that, this is a lot of acronyms.
Yeah,
I'm
that's
sorry.
Okay. No,
I'm going to
that's
try
all
to
right.
de-acronym as we chat. But basically it allows people to download Medicare beneficiary data. And why that's important that we're building it in the open is it allows for an ecosystem of different organizations to work with our data. Big companies, small companies, and it allows us to do it in a way where everyone has equal access to that software. And so we've stood up the first open source program office in the federal government. It was announced by the National Cyber Director in a recent report, kind of encouraging open source software in the federal government, and have built a small team at our agency who support across all of the centers and offices that we have, teams who want to open up different work that they're doing. And so not only do we have these APIs, we build our websites on Drupal, which is open source software. We have just released some of the data analysis code for the Medicare beneficiary survey, which is a long-running survey that we do. So analytic products, websites, tools to analyze data. And we're big fans of this, one, because it makes it more secure. We're scanning our code, we're looking at our code before we publish it. We have extra eyes every time we release it to the public. We have other people looking at it. Many eyes makes less bugs, right? So they'll say, hey, I think there's a bug in your software, here, fix it. And we're actually introducing new programs to keep an eye on that software after we launch it, right? And so it's a cybersecurity posture, as well as building a sharing ecosystem in the healthcare space, where others can build on top of the work that we've done.
Did you run into resistance as you were building that culture, or has it been inculcated long enough at CMS that people didn't really give you a hard time when you wanted to scale?
It's been there long enough at CMS. I think this has kind of been a long time coming, and pockets of the agency were really mature, and what we are focused on at the OSPO is making sure that the rest of the agency can catch up to the mature teams that are launching lots and lots of open source software on a regular basis, and that we're providing training and support and templates and tools for the rest of the agency, and kind of raising the floor. And that's been the exciting part of this, is that we were already doing this, and it's just how do you take the best practices and scale those across the agency.
Sachin, welcome. It's great to have you on the program. You were talking before we went on the air about the free flow of data and the data exchange that's important in these digital transformations that organizations are undertaking. It sounds like that syncs with the kind of thing that Andrea is talking about at her agency.
I think it's critical. I mean, Andrea, what you're doing at the scale of CMS is going to unlock value for the entire ecosystem. If you look at these major, we think of them as the major pillars that are being put in place across the industry, the electronic health records, other core systems. If you don't have data transferability between them, if you don't have the ability to look at somebody kind of longitudinally, not only are you going to have access issues in terms of getting information, but if we think about the kind of underlying crisis that's going on in this country, is that we still have been treating healthcare episodically rather than across the continuum of care. Nobody has a healthcare episode, right? Mm-hmm. We all have healthcare needs that develop and progress and change over time, and so to think about the data flowing relative to how we actually experience healthcare is critical.
What does that mean, Sachin, for the way that people should be thinking about building infrastructure, not just at CMS, but all across the federal government? And again, with that kind of latitudinal and longitudinal approach that we talked about in the first part of this program, which is the providers in the federal government, but also the private sector organizations like the ones that Andrea talked about partnering with.
Yeah, this is a topic of some controversy amongst the commercial providers of electronic health records, right? There are different postures on the willingness to be open with APIs, as Andrea mentioned, and you know, willingness to access data, because it opens up a significant question on who actually owns and controls that data. But you know, to answer your question, Francis, I'm a big proponent of open APIs. It's what we do at our company. Our expectation is that as more data is created, this idea of interoperability actually needs to go on steroids, so that you're integrating in and out of other systems and being able to provide that contextual view of any individual, not just for that patient's benefit, but we heard in our last segment that providers are frankly under duress, and that's not an episodic thing that's happening in this country. That's not a crisis. That's sort of the new normal. You know, we're estimating that over the next decade, the provider shortage is just going to continue growing up to over 100,000 physicians by the mid-2030s. And so if we don't think about structurally solving that through unburdening their limitations that happen when they don't have access to data, then we're simply going to add to that crisis.
The term that you're using to describe that is healthcare desert, similar to what we hear about food deserts. Are those the factors that are leading to what you use that term to describe, Sachin?
Yeah, I mean, if you think about it, we are not going to be graduating more people from medical school and nursing school than we really can be, right? That's not going to be the major rate factor that changes. And we should have, if we are more efficient about it, we should have enough providers in this country to serve the population. We are, you know, the most advanced, largest country in the world in that sense, and yet just putting a military lens on it, right? There's a recent NPR report that came out that over 45% of you know, military beneficiaries are in a federally defined healthcare desert, and that's going to hit the people with polychronic situations going on. It's going to hit the maternity population, which is already happening more broadly in the industry, and so we're not doing the people who are sacrificing a lot for this country, we're not doing them a service at all, right? At not some small scale, but we're talking about half of beneficiaries that sit in these deserts, and so we have to think about not solving it through the old ways of adding more expensive brick and mortar and human capital infrastructure, but there has to be a digital alleviation of that pressure point.
So one of the elements of that digital alleviation that you told me recently, Andrea, you said without open source, you can't have AI. Why is that, and how does one move from one to the next?
Yeah, oh man.
Or am I maybe not even thinking about it right?
No, I mean, the way I think about it is the foundational models of AI we're all built in an open source ecosystem. It takes a lot of resources and infrastructure and a lot of research projects, which many of these models start out as open source projects where people are working across the ecosystem. And for me, when I think about the government doing AI, one of the biggest risks, and we hear often people are scared of, is lack of transparency, lack of knowing what's in the algorithm, what's in the box, right? And people keep using the analogy of a black box. We don't know what's in it. We can't see it. How do we build transparency? And the only way I know how to do that is to do it in the public, do it in the open, and be transparent just in the way that we're actually building the code. So use the foundational models that are open source and do our fine tuning, do the actual training of these modules in the open as much as possible. And so that's, you know, one, it's part of how you got AI, how we got here to this moment that we're in, which I think is a pretty pivotal moment, that the large language models in particular have become very robust and are being used in many different use cases in the healthcare sector and in our economy at large. But what does this look like moving forward as a government entity or as a government agency? How do we make sure that we're being transparent and open and also maintaining trust with the public? And the only way that I think we can really do that is by having a really robust open source posture.
What do we do with that open source posture then to maximize this pivotal moment as you described it? What are the things that you see coming, or do we not know yet? Because, I mean, 2 years ago we didn't know artificial intelligence was necessarily going to have the kind of impact that most people think that it will have now. It was under
different flavors or different names.
That's right.
You know, like we've been doing machine learning for, well over a decade at CMS. I think I think what's going to change is our expectations of what is it being used for, right? I personally keep running into this experience in my own life right now where I keep getting AI assistance whenever I try to contact customer service, right? And it's a terrible customer experience service. You spend the whole time trying to talk to a human and not talk to the AI.
Yeah.
And that's what we want to avoid, right? We want to avoid making the process for our general public and our beneficiaries worse because we toss an LLM on it and now it's supposed to be more effective and efficient, and it's not, right? So I don't know if that fully answers your question, but where we're going is understanding the use case and then building that software, building that tool that we're going to use, that AI model in a way that allows people to trust it, right? Right now, there's a huge lack of transparency in this space.
I share your desire to just rage press 0 until I get to a human. Sachin, you wanted to add something to what Andrea was talking about there.
Well, spot on. I'd also add from a technical perspective, all AI/LLM models are actually designed to fail unless you feed it with more data, right? More learning to do. And if we create this wall between any beneficiary who interacts with the government or primarily interacts with the government versus patients who interact with the private sector and only let the private sector sort of lead, then these models will be trained to serve that model of care. And kind of going back to, we have unique healthcare deserts that are, a military beneficiary at a base who is pregnant and may not have access to postpartum care. And our maximization of this technology is dependent on making sure that data about that person is made available to train the model.
What is the right role, in your view, for industry and government to work together? And is there a way to think about Sachin, who does what, or does that not matter as much as there is a strategy, which we'll talk about later in this program, and that wherever the pieces fall, they fall? Do you get what I'm going for there?
I do. I think both matter. It's from my perspective, a matter of sequencing. There are things that we're talking about that, because it's big and a big ship to turn, that the government is just getting into now, that we can learn from what the private sector has been doing. Meaningful use has been around for coming up on 20 years now, and so providers have had to adopt electronic health records, otherwise their reimbursement from Andrea would have been disrupted, right? And
well, she's not writing the checks, but I get what
I don't
you told me that you write the checks.
I get what you're going for.
Yeah, and so there are out of frankly need, right? There are things that health systems and providers around the country are doing that we can learn from. There are also things that they have done ineffectively that we can learn from now that we're doing electronic health modernization and digital first and these sorts of things. So I think that's one area. And coming from more of a private sector background and spending more time with the government, I do see a lot of opportunity for better collaboration there. But then going back to your question, are there structural things that could be done too? We have a supply-demand mismatch in this country in terms of people's ability to access care, and that supply-demand mismatch is exacerbated in areas like the VA or active duty military. And so are there things that we could do where the private sector is making capacity available in those situations, and they're doing so in a way that is on their terms without sacrificing their patient populations and their needs? And so I also think technology is sort of the great hope there in order to see some of that smoothed out.
Andrea, at the beginning of the conversation, you talked about how open source facilitates cybersecurity.
It does, yeah.
You have done a bug bounty program with the Cybersecurity and Infrastructure Security Agency. What were you aiming for there, and what did you learn from that process?
Yeah, so at DEF CON this year, we launched a vulnerability disclosure program first, which is a safe harbor. So we run large-scale websites at CMS, healthcare.gov, medicare.gov, medicaid.gov, to name a few. And so we worked with CISA. CISA has a program where we were able to join them in basically asking the hacking community, take a look, or the security researchers, to take a look at these websites, and that we would sign up as part of their vulnerability disclosure program, and that we would close those bugs quickly. So if they're reported to us, we made a commitment that we would get them cleaned up fast. And that has been incredibly successful. We followed that up working with their Bug Crowd program. And to me, part of what, so this is being led by our open source program office, and part of what's exciting about having our kind of, like, we call it source code stewardship, so making sure we know where our code is, who's in it, and what it does, is part of that. And then having ways of, hey, you're submitting bug requests to us and pull requests, and that we have ways, if you find something that might be leaking PII or PHI, or something that is a real, like a serious vulnerability that we should know about fast, that we have a way for you to get that. And in fact, bug bounties are awesome because we pay people for them, right? So it's much more beneficial for us to pay people up front for bugs than to deal with the aftermath. And so it's a much more, less reactive, more proactive approach to cybersecurity, and a new way of thinking about it. There are very few agencies that have signed up for this program with CISA, and I think it's a wonderful program. It's funded through CISA, so it costs us $0, which everyone in government
Everybody loves $0.
They always love when the cost is zero.
Huge fan of that.
Yeah, $0 to join their vulnerability disclosure program, and it's a great way when you think about how the government engages with that community as well, the security research community or the hackers, that we're kind of all in one place. They can go, they can see who's going to pay out, who's not paying out, and they can actually support us in a new way. I think it's a cool idea. I mean, and it's fun. It's a fun program to run. Yeah,
I would think just the fact that you were at DEF CON is, I mean, that's kind of counterintuitive to the way that I would think about a civilian government agency.
Yeah, Medicare is at DEF CON, right?
That's right.
Yeah, we were there with our age.
What do you learn at an event like that that applies to what CMS does on a mission delivery basis every day? Yeah, I mean, the way the internet works it's changed a lot. I mean, I think I was listening to something this week where they talked about the dark web being like the third largest economy in the world now, right? And Medicare beneficiary data is very sought after data, for example, for Medicare fraud. And so making sure that our leadership and our staff understand what is happening and what the trends are in cybersecurity is critical for us for Medicare fraud, waste, and abuse. It's critical for us for making sure that we're protecting our programs and that we're able to keep these websites up and running and productive, and protecting our beneficiaries. It's no longer a world in which somebody is stealing a piece of paper to get your information. It's all happening online. And so making sure that we are part of that understanding, that I think a big part of it for us is making sure our leadership and people who are running these programs understand the risks that are out there, and how the internet works, right? Because it's really what it's about. It's how the internet works today. I mentioned at the beginning of this part of the conversation, Sachin, that the way that organizations in government and in the private sector think about software is different now than it was a couple of years ago. Should they also be thinking about infrastructure then differently based on what Andrea just said? Absolutely. I mean, infrastructure used to be a hardened capital expenditure that you amortize over a 15, 20, 25-year period, right? That's the sort of classic definition of infrastructure. If you apply what Andrea just said about cybersecurity to that paradigm, it would take about 6 minutes for the infrastructure to be penetrated, right? So for us to think about infrastructure being an asset that's continuously evolving, literally the opposite of depreciating, right? But continuously getting more valuable over time, I think is where we have to go if we're going to enable all the data sharing and all the modernization that we're hearing about on the show. Which then, from a logical perspective, takes me back to the point that you made earlier about digital first. The only way to do that is to create a digital first environment, not just for the providers, but for the patients too. Am I on the right track there? Spot on, spot on. And I don't think digital first starts and stops with electronic health modernization. I mean, we have a challenge in this country right now, right at this moment, where we have some 800,000 reservists that are not able to be deployed because they cannot get scheduled for their mental health and physical health assessments. And if we think about the geopolitics of what's going on in the world, we have to actively think about a deployable ready force today, right? So the electronic health record will not solve that. It will enable and create the next challenge, which is how do we get access at scale to people who need it. And so I think there's going to be a modernization of the way that we think about scheduling. If you have a
22-year-old active duty reservist or active duty deployed, they don't want to get on a phone and call that call center and push 0 a bunch of times to get to a human being. They immediately want to be able to access schedules of people in their area, or virtually or remotely, whatever it may be, on their phone. That they literally grew up in an economy where they don't have to interact with anything but that. And so if we want to do that, we need to be able to accommodate that. If we have a 74-year-old veteran who does want to get on a phone, we should enable scheduling technology where they get on one call and they're not being called back, or they're not having to call in 3 times because they had to go track down a piece of information, but that one call is enabling the highly specialized complex care perhaps that they might need.
We have about a minute left, Andrea. As you move forward with a lot of these initiatives that you're talking about on this program and things that we've talked about in the past, how do you judge that what you've done is successful and that you can build on that and move to the next thing?
Oh gosh, that's a really good question. I think for me, part of what we're trying to do at CMS is build once, reuse many. So often for me, success is, okay, can we use this somewhere else in the agency? Can we reuse and recycle the software that we're building? Because a lot of these problems have been solved before, and I don't want to solve them again, right? So solve once, solve an issue, reuse that in different use cases. So that's usually my measure of success, and that's one of the reasons we've been so focused on open source, is because it allows us to see where's a tool that we might have in our toolbox that solved a similar problem before that we can just pick up and reuse rather than having to start from scratch.
Andrea and Sachin, it's great to have both of you on the program. Thanks very much for joining me today.
Thank you so much.
Thank you, appreciate it.
You can read more about open source and software in the health IT sector in government at fedgovtoday.com. Up next, a digital transformation isn't the only one underway in federal health IT. In Depth continues in just a moment. If you want insights from agency and industry leaders on the latest topics in technology, management, workforce, defense, and acquisition, sign up for the FedGov Today podcast with me, Francis Rose. I release new episodes every Tuesday and Thursday, so you'll stay up to date on the issues that matter most to federal government leaders. Listen at fedgovtoday.com and everywhere you get your shows. Don't miss out on the conversation. Follow the podcast today. Welcome back. The Office of the National Coordinator for Health IT is undergoing a transformation of its own. It's taking a larger role in the health IT sector in the federal government and a more prominent role in the health sector more broadly. John Rancourt is Deputy Director of the Office of Technology at ONC inside the Department of Health and Human Services. John, welcome. It's great to have you on the program. You told me before we went on the air about a health IT strategic plan that is out from your office. What's in there and how does it fit with the themes that we've talked about on this program and with the work that you're doing with the healthcare community, both in government and outside government?
Well, Francis, thanks so much for having us. And let me start out just by sort of reintroducing my agency, which just underwent a name change. So we were the Office of the National Coordinator for Health IT, and now we are the Assistant Secretary for Technology Policy. And this change was part of a reorganization within HHS that was looking to establish HHS's focus on technology innovation as a strategic priority for the department. It's also part of the establishing the work that we had already been doing cross-agency to collaborate within the department and across the government, and advanced work that we've been doing for years on technology and policy. And so as part of that work, you just mentioned our strategic plan. We released that in September, and this is a federal government health IT strategic plan. And we collaborated with over 25 different federal agencies, counterparts, in order to try to project what we need to be doing as a government to get to where we need to go for improving care for our patients and improving innovation and research. We also need to see that we improve the sharing of data within our healthcare ecosystem, and also making sure that we just promote health and wellness. So those are some of the key parts of the strategic plan, and yeah, we're really excited to be putting that into practice.
As I look through the pillars of the plan, a lot of them talked about technology or technologies, but they weren't technological in nature. A lot of them were thematic, I would say, in nature, in setting goals for executing on the strategic plan. Was that intentional, that you were not, that you were kind of almost technologically agnostic, it looked like?
Yeah, well, you know, in tech, they talk about people, processes, technology.
Yes.
You know, it is all of those things. And we think about it broadly in our work as well. While I sit in our Office of Standards, Certification, and Analysis, I previously was in our Office of Policy, and it really involves both in order to get to where we want to go. One of the sort of best examples I can give of that is our work on the Trusted Exchange Framework and Common Agreement. And so this is an initiative of ours where we are looking to establish the governance, policy, and technical floor for interoperability across the country, something Congress tasked us with doing in the 21st Century Cures Act. And now, as of December of 2023, we have a live data network that's sharing data under this baseline of technology, policy, governance. Really, you need all of those parts if you want to advance on health information technology policy.
All right, TEFCA is the acronym for what you just described, the Trusted Exchange Framework and Common Agreement. And I read this about TEFCA: much in the same way we can speak to others across all mobile phone carriers and banks can share information electronically, TEFCA delivers a nationwide framework to enable secure network-to-network health information exchange across health information networks. What did you have to do to get to that point, and who has to do what to perpetuate that so that we don't just reach a point where we've seen in other health IT, or excuse me, in other IT situations, government, where we go, okay, we got this nailed, and then we see a deterioration or backsliding over time?
Yeah, so the story goes back to, let's say, 2009 or so, when the Congress recognized that we had not digitized our healthcare ecosystem. It's still, at the time, you can remember seeing the paper charts in the back of the office when you went to your physician, and we don't see that anymore. And that's because through the HITECH Act and the incentives that were provided to physicians, we were able to digitize the nation's healthcare ecosystem. The problem was that those computers didn't talk to each other. And so Congress passed the 21st Century Cures Act, which gave ONC the authority to establish a trusted exchange framework and common agreement. And that was in 2016. And as I just mentioned, we went live in 2023. It takes a lot of time and work in order to make sure that we get those policies right. On the previous segment, you were asking about what's the role of government versus private sector. Well, both are essential in order for us to be able to make sure that we establish baseline privacy requirements, security requirements, and then allow for growth and expansion into other areas that data exchange had not been happening for. If you think about public health, during the pandemic, data was not where it needed to be, and in the sufficient quantities, et cetera, and quality. And so part of TEFCA is enabling public health data exchange through this network of networks. So it really is a collaborative effort. It does take a long time bringing all of the right folks to bear on these types of large-scale public policy problems.
One of the technologies that was alluded to a couple of places in the Health IT Strategic Plan is artificial intelligence. And you used a term when we spoke last week that I thought was pretty cool. You talked about a nutrition label for AI. First of all, as a healthcare person, I see what you did there, so I enjoyed that. But the concept, as I thought more about it after we talked about it, was fascinating to me. What are you getting at there? And what will people read? The same way that I read, see ingredients and see what the nutritional components of something are, what will people see when they look at that nutritional label for AI?
Awesome. Yeah, let me just start by saying we as a department are AI optimists. We see tremendous opportunity in AI to do things like reduce inequities, improve the care experience, reduce physician burden, clinician burden, and even improve competition. However, there are risks, and those risks are that those things don't happen, or that inequity, for example, inequities are exacerbated. And so we as an agency issued a final rule last December, our Health Data Technology and Interoperability final rule, which established transparency requirements for health IT systems under our certification program. These are the systems used by 96% of hospitals across the country. And what we did is, like you said, established a nutrition label for AI. And the nutrition label, we wanted to mirror after the executive order on AI, which talks about AI FAVES principles. FAVES meaning fair, appropriate, valid, effective, and safe. We want to see AI systems that are those things and not the reverse, which are the risks. And how can we get there? How can we balance that ability for the private sector to innovate, to create these new solutions that solve problems for clinicians, but also respect, the risks, and that's where transparency comes in. And what we've said is these systems that are certified under our program need to be able to present that nutrition label to users of the system. What does that look like? Well, if you're a user, you should know what is the name of the developer of that AI tool, who funded it. It would make a difference for you if you knew that this tool that was recommending certain therapeutics for certain care was developed by a pharmaceutical company. That doesn't mean that it's necessarily bad. It could be the best thing on the market, but that transparency is important for a user of those tools. What else would the label include? It could include things like the intended use of the product and the out-of-scope uses of AI. So if there's a population that this tool should not be used on, that needs to be presented very clearly to that clinician. Performance metrics on is this tool fair, is it valid, those kind of things. That's what we have done through our rule. And so you were asking what would you see. This is more of a tool for clinicians, as the scope of the program is for electronic health records, health IT that's used by more clinician types. But this is a framework that is, like I said, part of the executive order. And so we'd be happy to talk to any of our federal partners or others about, how this could, help with their types of programs as well.
We have less than 30 seconds left, John. How will you judge overall the success of your health IT strategic plan, but more broadly, the health IT delivery and platforms that agencies are using across government?
Well, fortunately, the folks who worked on the strategic plan thought very hard about that included objectives and, benchmarks, et cetera. And so we monitor all of that to ensure that we are making progress all the time. But sort of more broadly, I'll just say that, things like the reorganization that I mentioned earlier, a recognition of just how important this work is and how important health IT is for all of healthcare.
John, it's great to have you on the program. Thanks very much for your time.
Thank you so much, Francis.
You can read more about ONC and the work they're doing at HHS at fedgovtoday.com. As you've probably learned from this program, the health IT landscape in government is already filled with potential for the future and projects happening now. You'll stay up to date on FedGov Today TV Sunday mornings at 10:30 on ABC7 in Washington and on our YouTube channel, on the FedGov Today podcast every Wednesday, wherever you get your podcasts, and always on demand at fedgovtoday.com. My thanks to our guests from the firm, CMS and ONC, and our sponsors from Maximus and eVisit. I'm Francis Rose. Thanks very much for watching.